Beginning, and I know that you're all very busy, and so I really want to thank you for taking time out of your busy schedule to join me tonight. And again, many educators ask if these are recorded, and the answer is yes. You can go to my YouTube channel, Think Like a Nurse, and you can subscribe to that channel, even better, and you can be able to basically access prior Facebook Lives. We did a series on clinical judgment over the last 3 months that had 7 parts, so that's accessible there. I've got shorter YouTubes on the same content, and so I just want you to know that this is all recorded. It lives in perpetuity on the internet. And thank you again for joining me tonight. It's great to be with you. Love to know who's out there tonight. So if you are in the chat, I'd love to just put your name out there and let me know where you're from. And just a personal thing I just wanted to bring out, actually a professional, is that one of my highlights last week, I took a much needed break and took a drive down to Kansas City and went to University of Kansas for the Professional Identity in Nursing Symposium, led by Dr. Nelda Godfrey, who's been leading the initiative on professional identity in nursing. And if you're not familiar with this work, you really need to. And Dr. Godfrey is doing some incredible work with really kind of just identifying the essence of what is professional nursing practice, defining what we do. And, the 4 pillars of professional identity include I've got to get it right. It's the values and ethics of our profession. It's the knowledge of our profession, including the importance of clinical judgment, the leadership aspect of our profession, and the professional comportment or professional behavior. And, Nelda's vision is to have, in essence, to really, use, when you know your identity, and you know who you are and what it means to be a professional nurse, in the struggles that nurses are having in practice with COVID and burnout, that identity can be a source of healing to wounded caregivers. And so, the essence of professional identity is the ability of the nurse and knowing what it means to think, act, and feel like a nurse. And if you're interested in this work, I want you to know that they've got several work groups that you can get involved with. And what I'm going to do is pop in Nelda's email, and she would love to hear from any educator out there directly, and to basically see how can I get involved. I'm in the educator work group with Beth Phillips and Susan Luperell. We're developing some incredible resources for nurse educators to provide tools, kind of like a professional identity toolbox on all of these 4 compartments. And it's been a blast in sharing some of the things that I've developed with Keith RN and other things that I'd love to share on a broader scale. So if you are interested in any way to really kind of give back to the profession of nursing, I want to commend you to Dr. Nelda Godfrey and her work. And so I just want you to be aware of that. And if you're wondering who this guy is, my name is Keith, and I am the founder of Keith RN. And, my passion, I began Keith RN about 9 years ago just to serve the needs of educators by creating innovative tools and resources to bring clinical reasoning, clinical judgment, practice these skills, and really kind of provide some of those essential resources and those tools that we all need to strengthen and practice clinical judgment. So it's really my pleasure to do so, and it's a pleasure to have you with us tonight. And, we need to take down some sacred cows. When I started Keith RN 9 years ago, NANDA, 3-part nursing diagnostic statements were really still out there. And fortunately, we're pulling back on that because it doesn't capture how a nurse practically thinks. But another sacred cow that we're going to look at tonight is physical assessment and how we teach it in nursing education. And I don't think it would surprise any of you that we are teaching TMI with physical assessment skills using the vernacular of Infobesity. We clearly are teaching too much, and I'm excited we're going to go deeper in this topic tonight with a guest author, an educator who has written and published an article on this topic. And so just want to see who's out there tonight before I go on any further. Amber's back again from Nebraska, Pauline from Florida, Got Sandra from Corpus Christi doing health assessment. Wonderful. Terry from Arkansas. Pam from Toledo, Ohio, the Midwest. Danielle from Georgia. And wonderful. You love the books you gave through Carrie Ann. Thank you so much. Joe from San Diego, New Jersey. Carol Daly is back. Pittsburgh. We have got educators from all around the country, coast to coast, the Midwest, and I'm here in Minnesota. And so it's a pleasure to have you with us. And, this Facebook is a dialogue. I'm not here as the grand poobah of nurse education. I'm really a facilitator. I want to be a guide on the side. And so I want you to kind of think about some of your questions that you have as it relates to this topic of nursing assessment. And when we look at the studies, there have been numerous studies that are communicating that we're teaching about 120 assessment skills in a pre-licensure course. Yet, how many do you think that we use as a core foundation for our head-to-toe assessment? It's about 30. 25 to 30. And there's been several articles on this topic. And, we're teaching way too much content. And as a result, our students don't get a sense of what is most and least important of our physical nursing assessment. And so I'd like to guess, I'm just going to ask a couple questions of the audience, and I'll wait a little bit for some of them to trickle in. But I'd like to ask you, why do we struggle in nursing education to simplify physical assessment and focus instead on a practice-based assessment, the bread and butter head-to-toe assessment? Why are we teaching so much information? Way too much, according to the nursing literature. Second question to percolate, what assessment skills do we need to eliminate in how we teach nursing physical assessment? And then the third question I'll throw out there, and we'll kind of go back and forth. What strategies have you developed to improve how nursing assessment is taught? And so I just going to let that percolate for a little bit. I'm going to throw in a blog link. I wrote on this topic about, this was about 4 years ago, on what physical assessment skills does a student need to know to be prepared for practice? And so I've got a couple articles. I didn't use Dr. Kinyon's study. It wasn't published then, since this was in 2021. And so the bottom line is that just going to put that in for your information and to take a look at that. And so anyways, I'm just going to basically pull in I've got my guest with me tonight. I'm just going to introduce her. Her name is Dr. Kathryn Kinyon, and she's an assistant professor at the Medical University of South Carolina for the past 5 years, where her prior teaching responsibilities were health assessment and pediatric nursing. Prior to her entry in academia, she was a pediatric pulmonary nurse practitioner and is a leader in community education, giving numerous educational lectures on cystic fibrosis and other pulmonary diseases. She's also a certified holistic nurse and has focused her research on perception of illness and holistic care. She's also the primary author for this article that is on the internet, and I will share it with you. It is called Improving Physical Assessment and Clinical Judgment Skills Without Increasing Content in a Pre-Licensure Nursing Health Assessment Course. And so let me get that in the chat here before we proceed, and I will pull in Dr. Kinyon as my guest tonight. So let me get this in the chat so you can easily access that. And Dr. Kinyon, thank you so much for joining me tonight. It is a pleasure. And where are you? You are on the East Coast, is that correct?
I am in beautiful downtown Charleston, South Carolina. It's an awesome place to be.
Wonderful, wonderful. Well, thanks for joining us tonight. And, when I look at this article, Dr. Kinyon, basically the essence of it, and I'll just kind of give the big picture, and then we'll drill deep with kind of the background story behind it. But you redesigned the health assessment course as a relatively newer faculty. And from what I got from the article as I read it, and I've marked it up, as you can see, this was a very fun article to mark up. I encourage all of you who are watching to go to that link, print it up and access it. But what you identified was basically focusing on the most important assessment skills. You identified through your review of the literature what assessment skills out of the 120 are most important. And then you develop some innovative clinical judgment skills, application activities, which I want to talk about, because clinical judgment and developing that reasoning that leads to the outcome of a judgment is obviously a relevant and hot topic. And you integrated assessment and clinical judgment. So you got to tell us kind of what you learned in that journey. But what you identified is that 33% of your students basically did not meet the benchmarks for your assessment. They couldn't do a good head-to-toe assessment. And basically, I don't know if you failed them, but they didn't meet the benchmark. You did some innovation, and 100% met the benchmark after your intervention. That's statistically significant, though I didn't see any T measures on that. But I know that from my background, going from 33, improving by going, by that percentage, it's going to be a P of 0.001 for sure. So anyways, Dr. Kinyon, let's talk about your study, talk about, yourself, your passion, what interested you in this topic briefly, but then let's dig in, because the educators watching tonight, they're looking for help. They're looking for guidance to say, how can we strengthen how we teach nursing assessment? Because that is so foundational to everything that a nurse does. As it relates to the noticing and interpreting skills of Tanner, to reason with the information you're collecting. So the floor is yours. I'd love to share your story, your journey, and your study.
Well, I'm a quality improvement person. I seem to be frozen, so I hope you can at least hear me. No,
yep.
Oh, there we go. So I have a doctorate in nursing practice. It's in pediatric nursing and nurse practitioner. And I have a master's degree in science, and I did some research with that. But mostly I focus on quality improvement because, again, I want to get the information. I want to make change. I want to see if it's going to be effective change. So when they handed me this course when I first joined, I kind of laughed a little bit and said, well, that's good. Give it to the pediatric nurse who doesn't do adults. But I think the advantage was that I came with some fresh eyes to look at it. And what started me really down this road initially was having conversations with both the students and the second semester faculty, finding that there was this big disconnect between what they were gathering and learning in our course and how were they transferring it and transitioning that information into med-surg. In addition, the students had such a high anxiety level about going into med-surg and how are they going to process all that information, that this seemed like a perfect opportunity to start scaffolding some learning. But again, I was astounded at the high complexity of skills that we were asking them to learn. And I laughed when I saw the tuning fork, because I also was like, yeah, okay, do we really carry around tuning forks in our pocket in the hospital to do our Weber? I taught the students, okay, Weber's up here, 3W, so they'd remember the difference between the Weber and the Rhine. But I thought, this is crazy. In pediatrics, you never percuss lungs. It's just it's not done. Never hook a liver. Well, I don't know. So here I was trying to teach these skills that I thought they're never going to use. And when we got these numbers back from the clinical faculty in second semester who said, the students, even if they show benchmark in the skills, they're not exceeding it. And in addition, they don't know what to do with the information they got.
It's too much.
They could crank through a vital sign or a blood pressure or listen to lungs, but then they didn't know. What do I do with this information? So that really made me go back and think through, how can I change this up? How can I really bring this down to what a bedside nurse needs to know, and then get them in that thinking, reasoning, leading to the judgment component that is an action.
Okay. So then tell us, Dr. Kinyon, basically, how did you whittle down 120 assessment skills down to about 30 that you really identified as your core? And I would like you to share, there's no sacred cows we can't take down. So what are some of those skills from your perspective and from the literature that we need to stop doing in nursing education and for undergraduate nursing students? We're not teaching nurse practitioners at a doctorate level. We're teaching undergraduate entry-level practice, generalist practice. So give us your short list, or maybe it's a long list of some of those things that we need to let go of.
So the article, what I did was I took all of the articles that had been published, the research articles where they had, looked at what nursing students were being taught. They looked at what the bedside nurse was doing. And it was amazing the consistency that showed up in these articles. There was a little variation, like some people counted vital signs and some people didn't, but there was really an amazing consistency in those skills that they really needed to know. So when we had 195 things they had to, in theory, learn to perform proficiently. And so when we went back, the areas where we hacked off the biggest chunks were HEENT. So we're not doing otoscopic exams or ophthalmology, otoscopic, and my brain has stopped. We're not sticking speculums up people's noses. We're checking for nasal patency, but we're not looking for nasal polyps. We're not checking, for the retina. We are looking for the red reflex because in the peds world, that's important to me. Abdominal, we got rid of 73%. Musculoskeletal, we got rid of 74%.
Give us some examples, Dr. Kinyon, for each body system. Just highlight 2 or 3.
So we got rid of the Weber and the Rhine, and you do the whisper test to check for hearing. We got rid of, I already mentioned the nasal patency and looking in the nose. We got rid of percussion for the chest. We got rid of, I'm looking at I pulled up the old list and the new list of our checkoff sheets. We got HENT. So let's see, we got rid of looking for lymph nodes. Some of these things sort of blended. We didn't do a thyroid exam anymore. We didn't palpate all the body systems for the lymph nodes. We didn't percuss and palpate for sinus cavities. Tapping the teeth. I always thought that was hysterical. And get that tongue laid out and tap those teeth. Let me click back up to the top. Skeletal muscle, we really focused on the main systems for musculoskeletal, so that there was a little more importance in that. And I'm going back now to dig through, make sure I don't forget any of the musculoskeletal things. We got rid of an awful lot of neurology when it came down to like deep tendon reflexes. We basically kept the patella reflex because you need that for obstetrics. And then the plantar reflex, we kept that one. We did keep all the cranial nerves just because that's a lump sum. And so some of the articles talked about clustering care or clustering particular assessment skills. And so we felt then that's where the group comes in. So there were 3 or 4 of us on this article, and we sat down as a team and said, okay, here are the 30 skills that we clearly need to teach. Are there other skills that we're teaching that we want to keep? And so Ms. Dalton is a neurology nurse among her other talents. And she said, no, we really need to keep a few of these. So we ended up keeping a few more neuro skills, some of the cardiac skills. I'm looking again.
Dr. Kinyon, one of the, Amber is asking, providing details on your neuro skills. And so what I'd like you to clarify for us is this. When it comes to neuro assessment, this is kind of a bugaboo. There's 2 levels of neuro assessment. There is the bread and butter for the focused neuro assessment for a patient who is a non-neuro patient.
Right.
And then there is the neuro assessment for your patient who has had a stroke, and now you're just doing those reassessments and you do a much more detailed neuro assessment. I think it's really important that, since most patients are not primary neuro patients, what is the essence? And I think what Amber is asking is basically for your basic neuro assessment for a non-neuro patient, what are those essential skills that you identified and what the literature supports?
So again, we used to have this whole big mini mental assessment that they had to do. And I hate to say we threw that out. So it's more of looking at, orientation, obviously, memory and behavior. We did, like I said, keep all of the cranial nerves because it was easier to sort of make sure that they were familiar. Do we necessarily need to have all of them? No, nobody's going to carry around a little pocket of coffee and check your smell. We did do an evaluation of for speech. We got rid of a whole bunch of the sensory stuff.
Like what? So
stereographic was one of them. So what we've left in, let me go back. I've like I said, I brought that up. So we got rid of vibration. Stereogenosis, I can never say these, but one was, stick it in the hand and can you tell me what it is? And the other one is I'm drawing on your hand. So we got rid of those. Like I said, we cut down on the number of deep tendon reflexes to just the patella. We also got rid of all sorts of these so we did do some gait and some looking for, these are not necessarily in that 30 list, but again, felt that it was important to look at a patient from a Romberg and a pronator drift. So we kept those, but pretty much got rid of all of this. Can you calculate? Can you do abstract reasoning? Can you do thought process, which was in our systems? We used to make them do tricep, bicep, brachial radius, Achilles, deep tendon reflexes. We did touch to pain, light touch, vibration on the sensory. We got rid of all of that. On the cerebellar function, we got rid of the finger to nose one. We got rid of the thigh tapping, the heel tapping, and the toe tapping. And we just went back and left with looking at walking balance for gait and for lumbar and pronator drift. So that's the neuro exam. Now, again, pupils come in under the cranial nerves. So again, there were some of those things that when you keep those whole cranial nerves that kind of lump together, but that's what we used.
One of the questions that is out there is, and let me look and see, it says, for Andra asks, can you provide a list of what you expect in an assessment? And what I would say, Andra, is that download Dr. Kinyon's article, because it has right here, I don't know if you can see it, it has a beautiful summary of the 7 articles, and it has all of what's similar and what is different of the core assessment skills inside the article. And so I think many of us as educators are looking, well, what are those core? Dr. Kinyon did a wonderful summary across those 7. So you can all see what was the most consistent of the 30 or so skills. And like she said, they're really consistent. And so this is really implementing best practices by looking at these core as a foundation. And again, I'm just curious, Dr. Kinyon, one of the thoughts that I have is that why do we not scaffold how we teach nursing assessment? So why don't we start with a core of those 30, lay that foundation in the first year, and then those more advanced skills like the deep tendon reflexes that are, again, part of that equation, but they're not as common and they are more difficult. Why aren't we scaffolding assessment in a different, at the second year, for example, in an undergraduate nursing program? And are we giving too much at one time, even with some of these more nuanced skills? Just a thought. Any feedback on that?
Well, we're an accelerated program, so
Okay, so you're just going. You're go, go, go.
Their feet, and they're often going. Now, what I have told the lab faculty is, here are the core skills they're going to be tested on, and the students know that. If I'm in lab, and actually we do a telehealth module in health assessment because we can. And so I have a telehealth cart, but the cool part about the cart is that it has a way for you to really see when I'm examining ears and looking at the eardrum. It's up on the screen so we can have conversations about it. So I've actually brought that into lab when we were doing telehealth, and using that and going over. So that's some of those advanced skills, but that's not their responsibility. So, I mean, I know a lot of our students are very interested in wanting to go, not be a bedside nurse forever. Unfortunately, they want to move on to become a nurse practitioner or a nurse anesthetist. But we do, I encourage the lab faculty to their comfort zone to share other skills that they are. But again, we really just focus on these core skills. I did restructure our lab. It was a 2-hour lab. And COVID kind of threw sort of a monkey wrench in a lot of things we were doing, but this is the first semester we are now back face-to-face, and can actually have a face-to-face conference time. So the students actually have a 2-hour lab where they're really practicing skills. And then there's a 1-hour post-conference kind of session where they now are developing a concept map for a disease that relates to the system they just did. So for cardiology, cardiovascular, it's a DVT. And so they write a full concept map to, again, prep them for med-surg. And then there's a case study that they have to find all the cues in the case study. So they start practicing. Actually, they started this week 5. They started looking at the cues. Now, I've written all these case studies from a holistic nursing point of view in my poor little brain. So there's a whole bunch of psychosocial, environmental components that they need to tweak out of that. And then they need to look at what would you expect to find on physical exam given this scenario that, again, ties in with the concept map. So again, they would have done a concept map on DVTs, looking for risk factors, signs and symptoms, yada, yada. And then they have to figure out what are my first, second, and third priorities. And then they have to identify 3 areas of teaching that need to be done. And the thing we've instituted this semester, which I stole shamelessly, is an empathy map. So they are going to have to complete an empathy concept map. So again, trying to get them out of the doing stuff and getting them into the being of a nurse. So I'm excited about how that's going to be unfolding. The other piece that we did incorporate, and that was our students developed, was a gender inclusion module. And that's part of our interviewing, but they are also practicing these gender inclusion questions as part of that introduction. With each time they do an assessment in lab, they have to run through all of those questions in a way to, again, create muscle memory for that will just naturally flow when they talk.
Okay. We do have some questions coming in, Dr. Kinyon. So let's take a moment and let's answer those. I'm just going to back up here and saying, basically, Jackie asks, when you're evaluating, I'll just pop it on the screen here. When you're evaluating their proficiency at testing them, do you make them verbalize the names of the cranial nerves, sensory, motor, or both?
Oh, no, I won't. So what the students do at the end of the semester is they need to talk through what they're doing like they're talking to their patient. So I'm not going to tell, you wouldn't talk to a patient to say, oh, well, your sense of smell is the sensory cranial nerve 1. But they do need to talk through what they're doing so that, again, I, who am observing them, know, but I'm also listening to how are you talking to your patient? Are you explaining it in a way, because jargon is such a hard thing to get them out of. Well, we're going to check your stats. I'm in the peds world. That means I'm sitting someplace, right? So they just have to talk as if they were talking to the patient.
So you really bring that context. So when you're doing like the check off, you're having them, like your old way of doing it was only like they did like a Russian roulette with 2 body systems randomly.
And they all were like, please, please, please don't give me neuro, please, please.
Yes. And so now what you're doing with your check off is that you're having them demonstrate a complete head to toe assessment, a talk aloud, think out loud as they're doing it, but also interacting as if that was a patient and showing that holistic aspect to the skill as well. And you're assessing all of that in your checkoff. Am I understanding correct?
Right. And then they, of course, have to sit down and write it up. And they do get a cheat card. It's amazing how small they can write. But they don't get the card when they have to do the full write-up. So I don't allow them to use like a DocuCare. They have to pull this information from their brain, again, hopefully with some muscle memory, as that final part of their whole checkoff. So it's perform the physical exam and then it's write it up.
Okay. And so I want to kind of start from ground zero. So the first thing that we need to do from what Dr. Kinyon's study is that we identify the core 25 to 30 skills. That's in the article. That's in the chat right now. That's the beginning. Then what I want you to kind of resituate, Dr. Kinyon, is basically the clinical judgment exercises. And my question is, would you do that for every body system? So as you're teaching like the cardiac, you have a cardiac concept map with the problem and the data that needs to be extrapolated. Then you have a case study that goes with that. And then you have, the empathy map. I mean, was that done for every body system, or that was unclear to me?
Yeah. So these are babies. I call them my babies. So the first few weeks, we kind of get the groundwork laid. I'm so glad that I have dumped, no offense to the people who did nursing diagnosis, but I have dumped nursing diagnosis happily. In health assessment, we are moving away from that. So the first few weeks are just trying to get their feet wet. So this week we started with general survey. And this is the first week where they're having to really begin to apply that information and start writing things up. Then next week is respiratory. It's a big one. It's my area of expertise. Yeah. So again, when I talk to and my lab faculty, I've made an orientation manual for them. So when we talk about the patient, it has, I think it's asthma, but I can't remember for sure. But what I want them to be thinking in this conversation, this 1 hour conversation where they're all together, is when you say somebody has a cough, right, or they're wheezing, well, what other systems might be involved with that? If it's a patient who is elderly, are there heart issues that might have them wheezing? Is there something else going on so that you would want to look for edema or high blood pressure, so that they're beginning to see that a sign or a symptom has some intertwining with multiple systems. And again, that's where the concept map talks about, yeah, here's where you're going to write your signs, here's going to write your symptoms, but let's talk about review of systems that might relate to this particular thing, so that when you're doing that assessment, you're also thinking that I may need to want to look for those things as well. The empathy map is you're writing, what do you think that patient might be feeling? What are they saying? What might be behind? Patients will say, I'm fine, but you're looking at them going, yeah, you're not fine. So the empathy map, again, is a way for the students to start to think through. And this is the first semester we're doing it, so I'll be interested to see how this progresses out. But again, I'm trying to get them to think a little bit outside the box with that empathy map, as well as thinking outside the box for what kind of teaching. We always say discharge teaching starts the moment you're admitted. Well, if you're not thinking about it, what do I need to teach? What do I need to prepare for? You're at a loss. So,
yeah, excellent, excellent. Amber is asking this question. Could you share the tools you check off with, or any of the tools that you have, that you've developed, like the empathy map or any of the concept map? Is there anything that you can share or be able to, or not?
Yeah,
it's totally your call.
Facebook, I'm part of the Facebook Transforming Nursing Education, I think is what it's called, right?
Yes, that's the Teachers Transforming Nursing Education. So yes, if you're
in the files is my abdomen write-up to give you an idea of how that looks with an empathy map and the questions that they have to answer. What we've gone to this semester is, again, I keep tweaking this. So it's, we'll go back and reevaluate with student feedback and so forth, what they think. But this semester, I've dumped all of the subjective, do you have a cough? Yes. Do you smoke? Do you, all of that yes, no kind of questioning. And what I've done is written original case studies too for each of the systems. Wonderful. And now they're role playing.
Yep.
So
and that just brings that context plus the clinical reasoning of what are you noticing? What are you interpreting as you're doing a focused assessment of the body system of the week? And that's the missing link, Dr. Kinyon. That's really where it goes from being a skill or a task to developing the clinical reasoning that strengthens clinical judgment.
Right.
Well, that's incredible. That's really innovative.
Old cards questions. And again, creating that muscle memory of, I've done 10 weeks of asking old card questions. Okay, I know how to do this. And again, there are two different scenarios so that they just switch. And they have different chief complaints, but still related to the same system. But there's psychosocial stuff in there as well. Again, looking at that whole patient and whole family situation as a way to be successful in patient care.
I've got a really good question here from Polly Pete, who says, looking at competency-based learning, do you do this as a checkoff, and do they need to perform appropriately during a checkoff or during clinical? And what is your measurement of competency? So how are you quantitatively or assessing, that they met benchmarks? Like 33% were not meeting benchmarks before you did this intervention of bringing context to your assessment, limiting the skills to 30. How are you measuring? And how did you do that, Dr. Kinyon?
Probably not very scientific, but again, in my mind, you either know how to do an appropriate abdominal palpation or you don't. You know how to effectively listen to lungs in the right places and all the places, or you don't. So it's either you do it or you don't sort of thing. It's not a halfway. So you need to demonstrate that you can do the skill as we define it, which again is pretty easy. We have textbooks and all sorts of, you need to know, okay, I'm going to be listening to, the apex of the lung, or I'm, where all the parts are. So that's kind of how we do it. It may not be the most scientific, but again, I've seen students struggle, having been on the clinical side in the peds world. I've seen them walk in and they're just like, oh, I don't know what to do. So again, that's kind of where we're at. So they get a retry. So if they don't demonstrate competency, and they have to do them all, it's not like you get, you could miss 1 or 2 or 3. No, you have to do them all competently. You get a shot to redo it again to pass the course.
Okay. So what is the time frame for a typical student to do a concise, 30 skilled, head-to-toe assessment? What's the range of because we got to get our students prepared for practice, Dr. Kinyon. They don't have 30 minutes or 20 minutes for each patient and listening or obsessing about bowel sounds and this and that and all these other skills. It's like they got 3 to 5 minutes in practice. So my question is, how are they doing it? Obviously, this isn't practice yet, but how long does it typically take for a student to do? What's the mean approximately?
So when I did this revision, we had set aside for 2 students to complete their physical assessment. Well, let me rephrase that. They had 30 minutes to get their act together. So that was 30 minutes. Then they each had a half an hour to complete that 2-system head to toe, and then another 30 minutes to write it up. So 2 students took 2 hours. I didn't change that time. I just got rid of the 30 minutes that you had prep time, because you have your card, you should walk in the door and be ready to go. I did increase the time, because we were doing this full head to toe, to give them 45 minutes, which is an outrageous amount of time. I get it. And nobody needs that much, but it ratchets down their anxiety level for them to know, okay, I don't have to, race forward, I can stop. And so most of the students get through their physical exam, that full head to toe physical exam, in somewhere around 20 minutes.
Good.
Which is not bad. And then
then with practice and perfect practice and clinical experience, they get it down.
Right. Yeah.
So you implemented, we're going to wrap it up in the next 5 minutes, Dr. Kenyon, but, we've got some incredible comments. You can see people are giving you the applause by the chat. They're finding this valuable, as am I. And, so really well done. But the question I have is, we look at implementing needed change in nursing education. You saw a big area that needed to be strengthened, and it had to be transformed, literally, the physical assessment course. You implemented this change. I would love you to share just kind of what did that journey look like, and what were the challenges that you experienced to implement this change? And is that change still there? And so what can you do to encourage educators who are looking at not only physical assessment, but other aspects that are still a work in progress? What are some big picture things that you learned in your journey of implementing meaningful change and doing it effectively so it lasts and it strengthens and continues to improve everything in your program?
Well, I'm blessed with working with phenomenal colleagues, so that we are all and COVID's made it even more we've had to really become creative and imaginative. So that's been the blessing. So I didn't get a lot of pushback, I have to say. I don't have an awful lot of people, as long as I hate to say my Press Ganey scores are good and my students do, pass the course. And again, my test questions are not easy. They're application based, even in a physical assessment, health assessment course. So that part wasn't too terribly difficult. Once I went to my associate dean and said, this doesn't make any sense. And she's like, yeah, you're right. My biggest worry, and I'll be brutally honest, is these NCX Prep systems that we have to use, where I know that they're going to ask them, when do you use the Weber and when do you use the Rhine? And I'm like, so I worry a little bit about that aspect of it. And I think that may be where we want to put a little bit of our conversation, because I'd be curious with next gen, how much of these high functioning skills. I know that I think there are questions on percussing lungs, and when would you hear hyper resonance, and when would you hear dullness, and so forth. And I'm like, we don't need to know that. That's, we do. So I will mention, because somebody talked about bringing clinical into the classroom, more case studies. So our final exam is an unfolding, 8 to 10 part unfolding case study that ties in everything that they've learned.
So tell us about that. Kind of give us the bullet point. What does that look like? What do you do with that?
That's fun.
I'd love to know that.
The students love
case studies.
The students love it, actually. Okay. I did get rid of an exam that used to go with it for some other reasons, but you can do an exam with it in conjunction. The students it turns out to be like 10 pages long that they type up answering all of these questions. That's an individual piece of work where they have to, we don't tell them obviously what's on the case study, but they've done all of the prep work for those questions. Then they get randomly assigned to groups of 4, and that's the best number that we've found that's worked, randomly assigned to groups of 4. And every 15 minutes, a piece of that case study opens and they have to answer a series of questions. So one of them was, it looked like she started out looking like she was just depressed, when in fact she ended up with Graves' disease. But they had to roll all the way through. What was the last one I did? I've made 2 because they take a long time to really pull them together. But again, then the group turns in that whole answers as another component of their grade. And that part is actually open book. So they bring that prep work with them. So the students know you're in this group, you better have done your work, because you're going to be having to contribute to this conversation. So we unfold the case study in class. And then the fun part is wandering around, listening to the conversation. So there is a component that really helps some of the weaker students who might be really good with the social aspects of the conversation, adding, well, did you think about that? While somebody else who's really good with blood gases could do that. So it's a really good team exercise for them to walk out. And the students always write, oh my God, I didn't know I knew that much. So it's been a good thing to do.
So does that unfolding case study involve multiple body systems then?
So for sure.
Basically kind of covers all the bases of everything that they've had over the course of the several weeks of your assessment course. And now you've got that, that unfolding of, and then just touches the bases of those highlights of assessment.
Well, the other part is that I have collaborated with, again, because with our foundations nursing people and our pathopharm, so that the drugs that they've been learning in pathopharm get pulled into the case study. And some of those skills that they have been looking at or dealing with in foundations also get pulled in to the case study. So again, we're not siloing what you're learning. We're showing how in that case study, it all comes together in a way that for them, they can help to make sense. So again, the students love it. We now do these unfolding case studies in foundations, my course, and in the pediatric course.
Excellent. No, and that just ties it all together. And what you're doing is bringing that context to the content, Dr. Kinyon, and that's really that transformational shift that Dr. Benner identified 11 years ago in educating nurses. So it's exciting to see you implement that. And you're seeing kind of like I've seen with my Keith RN case studies as well, students, it may be more work, but they see the value of it and they like it. It's kind of like Mikey in Life cereal in the old commercials. They like it.
Yeah,
so
they do.
Believe it or not.
They complain a little bit, but then when they get through. The one thing we're doing this semester that is a brand new activity, I'm, again, constantly trying to tweak, constantly trying to scaffold, because the students struggle so much when they get to med surg because the volume of information is just overwhelming. We're doing a round robin, I'm calling it a round robin concept map. So again, in groups of 4, there are, because this is the number of students we have, there are 15 different diseases that each group will get 1. They will complete a full concept map. They will write an original case study. And because we have 2 sections, we're going to flip. So if section 1 group has asthma, say, I don't remember what they are, asthma, and section 2 did asthma, they're going to switch and read each other's and grade it. But then in class, one of the last classes that we're having this semester, they're going to rotate all these case studies through all the groups for them to then answer the questions, and they'll get the answers from the original group that wrote it. So again, they're going to walk into med surg next semester with about 25 concept maps done that they can build on as they go through med surg. So I'm excited to see how that goes and to see if that really ratchets down their anxiety. Just as one last thing, I have an article published in the Holistic Nursing Journal called Beginnings. It should be out this October, that's talking about student stress. And that was also one of the integral parts of me wanting to redesign all of this, is I had to figure out a way to ratchet these students who were sitting on the ceiling, like panic stricken. I had to figure a way that I could make this better for them so that they could in fact focus and be successful.
Yeah, no, excellent. And you've got a couple more questions I'd like to quick address since we've got a live audience here. Just going to throw out the last questions. We'll kind of have like a bullet session here. But this was a few minutes ago. But Kelly wants to know, what are your thoughts on more of a low stakes approach to evaluation with your, do you kind of like to raise the bar, or you want it? How do you, where do you go on this?
So I have moved to weekly quizzes that are 5 to 6% each, depending on which class I'm teaching. So they get a weekly quiz. That's low stakes. You blow it, well, move on. I have to leave the health assessment checkoff high stakes, but I haven't had anybody fail yet. So when they've been remediated again, they have lots of opportunities to practice these skills. So I haven't had anybody fail that, but I have moved to try to make things a little more, I don't want to say low stakes, because there's rigor in it, but at least, everybody has a bad day or a good day. So I'm trying to do that.
Yeah. And, Sally has this question, and I'll let you answer this. How would you suggest we start making the unfolding case studies? It seems very time consuming. Are these case studies on paper? So what are just some, I could answer that question really well, but I'm going to let you answer that one, Dr. Kinyon. What are your thoughts?
Well, for me, it's painful because for health assessment, I've had to make adult case studies, and I haven't been.
You're not an adult practitioner.
No, I haven't been an adult person since 1982. So that shows you how much I know. So they're a little painful for me. If pediatric case studies, I've got an asthma one that I'm trying to make a branching escape room. So they're not a quick thing. And I will work on a new one over the course of a semester, a couple hours a week, or I'll let it percolate in my brain. Where do I want this person to go? And then all of a sudden I'll have a brilliant idea and I'll wander off that way. So you just sort of start. You just start, and what is it that you want? What are the objectives that you want to get out of that case study? What is it that you want to confirm that they know something about? And that's how I do them.
Awesome. And, I'll just kind of share really briefly, my secret sauce is using Tanner's clinical judgment framework with case-based scenarios that I've written, and I've got a simple structure. And I've also got case studies on keithrn.com that are already pre-packaged, or I've got a membership site with 110 topics, including physical assessment and nursing skills, bringing context to that with the unfolding case studies as well that are about 10 pages in length, already created by myself and other educators across the curriculum. So I just wanted to throw that out there as well before we call it a night. And, you've got some comments here from Ursula saying, I love how you're doing mastery learning and giving low stakes ways to help memory. And I totally agree, Dr. Kinyon. You're doing some incredible work. You're just making it practical, best practices. And that's what we must embrace. We need to bring practice back into our profession and how it's taught. And that's kind of the pain point that I saw in my journey as a nurse educator who was immersed in practice and coming into it new. And I'm saying, OMG, what are we doing with how we're teaching assessment? I'm a nurse of 30 years. I've never done these. I've never gotten my tuning forks, my reflex hammers, my otoscopes. It's like, I just want to do a good breath sounds, heart tones, the CMS, those core 25 plus skills. That's what I do in 3 to 5 minutes, in the focused assessment at that. And so that's the aspect we need to kind of, go from that comprehensive head to toe. I'm just curious, did you talk about focused assessment and how you begin to focus on, with your patient, depending on, what they're here for?
Yeah. I don't do that in, this particular course.
I think it's too soon. I think that's an advanced skill. I can wait till second year.
Yeah, second semester when they're in med surg is when they're going to start, and psych. is when they're really going to start looking at some of those focused assessments. So I'm mindful of information overload. And truth be told, even though I have ratcheted up what we have them doing from a complexity point of view, it hasn't altered any of the time we've had to spend. We changed textbooks from a textbook I thought was really nurse practitioner oriented to one that I felt was much more nursing assessment oriented.
Would you like to share that one? Could you share it? I mean, it's just, what have you found to be good? Because we need to share the best.
Jarvis. I'm using Jarvis.
Okay, thank you for sharing.
Jarvis actually, and Jarvis just also has a workbook that comes with it. So I have stolen shamelessly from the Jarvis Jarvis workbook with, took all the vocabulary words and pulled them into crossword puzzles for the students to do.
What is the name of the Jarvis textbook?
What's the name of the Jarvis?
Just nursing assessment, or is there something more to it than that? And
yeah, it's Elsevier. It's an Elsevier product, and I looked at about 5 or 6 different health assessment textbooks, and Jarvis seemed to hit most of the things I wanted it to hit. Yeah. And again, like I said, the workbook, I have stolen some of their activities out of it. Not stolen because
right, but you borrowed. You're using it.
But then I have also, they have to do class activities. So there's also application. There you go. Somebody's already put it in. So I've also, again, I keep writing more case studies that they have to keep thinking through. So they'll do some of the worksheet things that I thought were useful out of the Jarvis workbook, but now we're going to apply it to something. So there you go. And I've been taking case studies that I've written, and I've been turning them into escape rooms with videos. So if you haven't tried an escape room yet, oh my God, they're so much fun.
Wonderful. Well, I'm going to throw your email on the screen in closing. Dr. Kathryn Kinyon, there is her email. And if you have a question that did not get answered tonight, or if you would just like to basically have some other information that you just would like to just pick her brain about, she's been gracious to share her email, and there you have it. And I want to thank you, Dr. Kinyon. This has been a really well-received Facebook Live. I love the interaction. I love the chats. People are finding value in what you're doing, and I just want to commend you and thank you. I just came across you in the Facebook group. As the admin of the Facebook group, that's almost now 9,000 educators, which is incredible, but you're a part of it. And I just happened to see a post from you, and I just said, I got to reach out to her. And here she is in the Facebook Live. And so I want you to know, educators, if you have done any research or published an article, or you're just doing something innovative that needs to get out there, like what Dr. Kinyon is doing, I want you to reach out to me. I'm going to be selfish here for a moment and just contact me by email, keith@keithrn.com, because I'm open to Facebook Lives. I don't have an agenda. I just want to get best practices and transformation in nursing education to our profession and how we're teaching it. And I just want to just thank you, Dr. Kinyon, for being a part of that needed change and all that you're doing. And if there's anyone else out there who would like to join me, like Dr. Kinyon, just email me with your strategies and what you're doing that's successfully transforming nursing education, and we'll have a chat as well. So anyways, any closing comments, Dr. Kinyon, that you would like to just, if there's maybe, is there a closing comment or just a nice little exclamation point that you'd like to leave our audience with tonight?
Well, I would say a semi-shameless plug. I will be hopefully able to post the article I wrote on student stress. I have taken the foundations components of when they talk about coping and so forth, and I teach that piece from a holistic nurse point of view. And I have a guided imagery, panopto, that I have given to the students. So if you have students that are interested in holistic nursing and self-care, and I would love to talk more about that.
Awesome. Well, there's your email address for anyone who has who wants to leave with that. And I want to thank you again, Dr. Kinyon. It's been a pleasure. And I wish you the best as you continue to work. And thank you as well. Blessings. And we'll stay in touch. I want to talk to you some more. I've got some thoughts that I'd like to connect with you on, and just some other future next steps. So I'll just shoot you an email and we'll continue the conversation.
So awesome. Thank you so much, everybody, for the questions and the input and feedback. Have a great day. Be safe.
Yeah. Thank you so much. Blessings. Good night.